Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello and welcome. Thank you for joining us for What's New, Doc? End-of-year updates for CAR T-cell therapy in multiple myeloma. My name is Dr. Joseph Mikhael. I'm a professor at City of Hope and the Chief Medical Officer of the International Myeloma Foundation. And it's my pleasure to share with you some of the really remarkable updates we have seen in CAR T-cell therapy over the course of this whole year. I would argue, actually, this has been a groundbreaking year for myeloma research in general, but specifically in the area of CAR T-cell therapy. So I'm going to be sharing with you really the things that are changing our practice and will continue to change our practice as we move into 2025 and beyond. So the way I'm going to structure the discussion today is to start with the two products that we already have approved in multiple myeloma, cilta-cel and ide-cel, and then we'll talk a little bit about some of the newer things that are coming that are quite likely going to influence us in the very near future. So starting with ciltacabtagene autoleucel, or for short, cilta-cel, this was a drug that was approved a couple of years ago in 2022, and it was approved in patients that had at least 4 prior lines of therapy. And in those lines of therapy, they had to be exposed, as we understand it, of course, with a proteasome inhibitor, an immunomodulatory drug, and a CD38 antibody. That was based on the CARTITUDE-1 study, which was really quite impressive at the time. We saw a nearly 98% response rate. We saw in those patients that did respond, the duration of response was a little bit under 2 years, and it has really revolutionized our practice over the last few years. But a critical update happened earlier in 2024 when the FDA now has approved our use of cilta-cel not after 4 prior lines of therapy, but as early as 1 prior line of therapy. And this was based on the CARTITUDE-4 study. And the CARTITUDE-4 study was a phase 3 trial that compared giving that a single infusion of cilta-cel to what would be typically the standard of care triplets that we use in patients who have 1 to 3 prior lines of therapy, combinations like daratumumab, pomalidomide, and dexamethasone. So things that we typically use. That study was really quite remarkable. So in that study, we saw that for the standard arm, the triplets that we would normally use, that the median progression-free survival was about 12 months or 11.8 months. In the cilta-cel arm, it still had not been reached yet. And as we've evaluated that data further along, it appears that that median progression-free survival is going to be over 2.5 years, if not even closer to 3 years. So this was really quite a major difference between the two arms, and of course led to that approval that now we can use cilta-cel as early as first relapse. And so for a lot of us in CAR T-cell centers using this agent, we often can use it now in as soon as 1 relapse. And I'll share at the end of the video a little bit more about my take on this and when I tend to use it. Since then, we've had other studies that have been done. There have even been some combination studies. I was particularly fascinated by one of the CARTITUDE studies, CARTITUDE-2, one of the cohorts where patients that had a bit of an inadequate response after transplant, hadn't gotten to CR or greater, were given cilta-cel followed by a lenalidomide maintenance, if you will, and we're really seeing tremendous outcomes. So using this agent earlier is really having an impact on what we're doing. We'll talk a little bit more about the toxicities as we go, but there have been some challenges with this agent, including neurotoxicities, but we are, I think, getting significantly better at managing them. And then just recently at the American Society of Hematology annual meeting in San Diego in December of 2024, we saw even more data coming out regarding the CARTITUDE-4 study in particular. One study that was fascinating to me was evaluating the MRD outcomes, minimal residual disease outcomes. You know, you can't go anywhere in a myeloma meeting now and not have a considerable conversation about MRD. And this study was evaluating the MRD outcomes as related to the CARTITUDE-4 study. And again, no surprise, we saw the big difference in PFS. It's no surprise there was a tripling of the MRD negativity when patients received cilta-cel as opposed to one of those triplet standard of care therapy. So it really is remarkable that we're seeing with CAR T-cell therapy not only the duration of response, but indeed the depth of response. And often those two things, of course, correlate together. And then just out of interest, there's some other areas that are being explored with cilta-cel, even as early, if you can believe it, as smoldering myeloma. Smoldering myeloma is a very hot topic in myeloma right now, but there was the CAR PRISM study presented by Dr. Omar Nadim from Dana-Farber looking at potentially even introducing this agent, albeit with small numbers yet, but introducing this agent in those patients that have high-risk smoldering multiple myeloma, that it's feasible, that it can be done, that patients can get a deep and a durable response. Obviously, the jury's still out on that. That's not yet changing our practice, but it gives you a flavor and a sense of what is happening. And the last cilta-cel study that I'll talk about, which I thought was really fascinating, was from one of my good friends in Australia, the Caramel study, where they're looking to be able to monitor where those CAR Ts go through advanced techniques of both imaging and injection, where we can follow those CARs. Because one of the things we want to understand, both from an efficacy standpoint and a safety standpoint, is where do all these CARs go? And is this perhaps, for example, one of the reasons why we see neurological toxicities? Do they go into the CNS? Do they go into certain parts of our neurological tissue? And so that Caramel study is yet to have a full evaluation, but it's something that we're going to learn a lot more about in the near future. So as I mentioned, we have two agents approved in multiple myeloma for CAR T-cell therapy. Cilta-cel I just described. The other is ide-cel, or idacaptogene baclusel. And this was actually approved even earlier, back in 2021. And that, of course, led to its approval and its use. And it was very similar to what I described earlier in cilta-cel. It was approved in patients that had 4 prior lines of therapy that included a proteasome inhibitor, an immunomodulatory drug, and a CD38 antibody. At that time, the response rate was 72%. It was the very first CAR T we had in multiple myeloma, but we also have an updated indication based on what was called the KarMMa-3 trial, and its approval almost absolutely in lockstep sync with cilta-cel occurred in the spring of 2024. And this KarMMa-3 trial was similar to the CARTITUDE-4 trial we described a few minutes ago, but this time it was patients who had at least 2 prior lines of therapy, so 2 to 4 prior lines of therapy, and it was again compared to pretty much the standard triplets that we would typically use. And in that population, the triplets gave us a progression-free survival of only about 4 months, but we saw about 13 months, a little over a year, for those patients that had ide-cel. So again, quite a significant difference between the two, leading to the approval of ide-cel now when patients have at least 2 prior lines of therapy. So for cilta-cel, we can use it as early as 1 prior line, for ide-cel as soon as 2 prior lines of therapy. And again, we see that this agent is particularly well tolerated. Often we can even give it in our older and more frail patients, and we see its efficacy and indeed its safety. There was one other study that came out this year that I thought it's important for us to include because it really is so important, was one part of the KarMMa-2 trial that Dr. Xavier Leloup presented at the European Hematology Association in 2024. With CAR Ts being available earlier, we just know it's going to be impossible for every patient at first or second relapse to get CAR T. We just know that, even from a delivery standpoint, from a sheer access standpoint, but also who is the best to get it earlier on. Is this something we want to give to everybody, especially as we're still learning a little bit more about toxicity, learning a little bit more about optimizing the way we deliver these agents? And so in this KarMMa-2 trial, they specifically looked at patients that we might consider functional high risk. What do we mean by that? These are people that within 18 months of their diagnosis, their disease is progressing. And we've looked at different cohorts, sometimes with or without transplant. But in this particular group, I was fascinated at how well those patients did with what looked like at least an 18-month progression-free survival in those patients that had less than 18 months the first time, and showed to us that in that highest risk population, we can break down some of these barriers of high risk, as it were, when we give them CAR T-cell therapy. And so I think it's validating our general approach, which is we're not taking everybody at first or second relapse to CAR T, but we're very interested in bringing those patients who relapse very quickly. That so-called functional high risk, not just high risk because they have cytogenetics, but they're demonstrating their high risk by the disease coming back quicker. Because what we've learned is typically the longest remission someone has is their first remission. So if it is short, then that is an unfortunate heralding of what may come in the future for that particular patient. And so it's important for us to try and optimize their outcomes. And so I think that Karma 2 trial really helped us appreciate that intervening earlier in higher risk patients with CAR T cell therapy is something that is very valid and reasonable to do. So we've talked a bit about cell-to-cell. We've talked a little bit about ide-cel. Well, what about the future? I think many of us are very excited about one of the most recent studies. I had the privilege of being a part of this study with patients from my center on it, with anito-captogene autoleucel, or sometimes known as anito-cel. And this was just presented with just under 100 patients, 98 patients, at the American Society of Hematology annual meeting by Dr. Kira Freeman. And a couple of things I think are really important about this study. Number one, this study, again, in a heavily pretreated population, had a response rate of 97%. So nearly all patients responded to this, with the vast majority of them getting into a complete remission, if not even into MRD negativity. So we see that incredible depth of response. Point number two, and possibly most notable, is that although there was, as expected, cytokine release syndrome that was typically manageable, the neurological toxicities here are significantly less than what we've seen with other CAR Ts, and in particular, less than what we see with cilta-cel, with no delayed neurotoxicities, the Parkinsonian syndromes that we've seen, the Guillain-Barré, even the palsies, cranial nerve palsies. We didn't see any of those in this study, even with, as I say, just short of 100 patients on it. So obviously we need more time and more data to fill that in, but to have that kind of efficacy with a lack of maybe our most concerning side effect of CAR T cell therapy, that neurological toxicity, is really quite encouraging. And then thirdly, it looks like we are going to be able to have a relatively rapid vein-to-vein time here, meaning the manufacturing process is typically happening in less than 2 weeks. So a lot of our patients within 3 weeks of apheresis get their CAR Ts reinfused to them. And I think that heralds, an opportunity to be able to keep patients moving through their treatment and treating them quickly, especially as we know in relapsed myeloma, where the disease can be very aggressive. So that is not changing our practice per se immediately because it's not yet available, but we all anticipate that we're going to be able to see it before too long. Of course, time prevents me from describing all of the other new CAR Ts that are coming. Well, what I'm particularly interested in is looking at CAR Ts that are dually targeted, where they have 2 targets on the myeloma cell. Other CAR Ts are coming that actually target GPRC5D. These 3 agents that I've just described to you target the BCMA, or B cell maturation antigen, on the surface of the multiple myeloma cell. But we're going to see other CAR Ts that target GPRC5D, like we're doing now with bispecifics, and possibly even with time some other targets like FCRH5. So things are really not only evolved rapidly in the last few years and this year, but I think these coming years, we're going to see a really remarkable movement in CAR T cell therapy. As I said, with these targets, even dually targeting. We did see one Chinese study with a dually targeted CAR T for both BCMA and GPRC5D. Again, preliminary results, but just proving that this is feasible, because unfortunately, we know that patients will become refractory to these therapies. They have not yet been curative per se, although patients thankfully are experiencing deep and durable responses. They're not curative. So as we come to wrap up a little bit, let's go back and say, what does this mean for the practicing clinician? Dr. Joe's been babbling here for a little bit, giving you all the data, trying to fit it all in. What does it mean? A few things. First of all, CAR T cell therapy is one of the most, if not the most effective therapies we've developed in multiple myeloma. I mean, seeing response rates over 70, over 80, now over 90% in heavily relapsed patients is really quite remarkable. But that this year we've seen that move to earlier settings where we can use cilta-cel now after one prior, even just one prior line of therapy, and ide-cel as soon as 2 prior lines of therapy. Secondly, every drug goes through an evolution. Every set of drugs goes through an evolution where we learn to use it more effectively to increase its efficacy and reduce its toxicity. And that's essentially where we are in CAR-T. We're now developing more outpatient programs, more careful management of cytokine release syndrome, in some cases, more aggressive use of prophylaxis like tocilizumab and steroids and things that we know can reduce the risk of cytokine release syndrome and other toxicities. That is really important, and perhaps even more importantly is using bridging therapy, and we should use the word bridging correctly. Bridging means the treatment someone gets between apheresis and the reinfusion of their cells, not their prior line of therapy. We think of that as sort of holding therapy, as it were, and that's important so that we not give drugs that will hurt T cells. But in that intervening period, the importance of bridging therapy, that can actually help reduce some of those neurological toxicities that happen afterwards. And then thirdly, just as I mentioned, looking to the future, that we're going to be incorporating CAR T-cell therapy into different strategies, different approaches, and with different molecules as we come to the future. So where does it fit in the bigger landscape of things? Well, I love that we have a bigger landscape of therapy in multiple myeloma. And we focus today on CAR T-cell therapy, but let's remember, we also have bispecific antibodies. We're quite likely in 2025 going to see the resurgence of an antibody drug conjugate in the form of belantamab mafodotin. Many of these therapies target BCMA, some target GPRC5D, and even other targets. And so it's becoming a complicated web, but we like it that way. We want options for our patients. Not every patient you have will be eligible for CAR-T, although let me say that the majority of our patients are. We even have patients that are transplant ineligible that become eligible for CAR-T. But if they're not eligible for CAR-T, we do have bispecific antibodies. We'll quite likely have belantamab mafodotin back shortly. And so this allows us to treat patients with the best therapy they have. I think I can say that in general, if someone is eligible for both CAR-T and a bispecific, we might tend to favor starting with that CAR-T. Give that single cell infusion. And then, unfortunately, when the disease relapses later, they could be eligible for a bispecific thereafter. That may be the preferred sequence than the reverse, where we're giving someone a bispecific continuously, and it may be harder to collect their T cells. Well, I hope that this has been helpful to you as you think about the care of your patient with multiple myeloma. CAR T-cell therapy has come a long way from where it was even just a couple of years ago in multiple myeloma, and I'm predicting that it's going to go a long way in the future. But right now, we have CAR T-cell therapy available for all of our myeloma patients who have at least had one prior line of therapy. We have 2 different products available, more products coming, and even more that are being developed right now to best care for our patients. All the while, our supportive care is becoming more effective as we care for our patients. So thank you again for joining us for the end-of-year updates in CAR T-cell therapy in multiple myeloma. Please be sure that you click on the landing page for this activity so you can claim your credit, be it medical or nursing credit. You can also access downloadable slides and look at other topics and other areas of interest to you as you care for your patients. So thank you again for joining me, and have a great day.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.